The national census in South Africa in 2001 estimated the prevalence of disability to be about 5% of the total population. The World Disability Report also recognizes that people with disability need to be able to access appropriate mainstream healthcare and rehabilitation to a greater extent than people without disability. Ironically, in many contexts, those who are in most need might be least able to access appropriate healthcare precisely due to the nature of their disability. In research that has been done, De Jong et al. In their medical expenditure panel survey found and concluded that individuals with disability use more healthcare services than those without disabilities. They also reported that adults with functional problems accounted for 1/3 of physician visits, 62% of hospital stays, and 46% of adult-related healthcare expenditure. South Africa, I think, like other middle-income countries, represents a classic example of the inverse law, whereby the lower socioeconomic groups bear the largest burden of ill health but have the lowest level of healthcare service utilization and derive the least benefit from service use. The aim of this paper or presentation is to describe the rehabilitation needs and unmet needs disaggregated by sex, age, and associated health condition among people with disability. It is hypothesized that a combination of functional limitations and environmental factors would have the greatest impact on access to services. The study was nested within a larger survey on the prevalence and epidemiology of disability. A descriptive cross-sectional household survey was conducted in an urban area in the Cape Town metropolitan area, which has the lowest score in the National Multiple Deprivation Index survey, indicating extreme deprivation. The sample size was calculated using EpiInfo, and in a population of 100,000 with an estimated prevalence of disability at 5.2, the sample required was 2,874 subjects. Instrumentation: the Washington Group on Disability Statistics short questions was used to identify people with disabilities. A demographic questionnaire was designed for the purpose of the study, and questions related to service delivery included whether the participants were aware of the different services, whether they needed the services, and whether they had received the services. There were also a general question relating to problems with accessing the services. The questionnaire was translated into isiXhosa, which is an indigenous language spoken in the Western Cape of South Africa. Ethical approval was obtained from the Health Sciences Faculty Ethics Committee, as well as the Western Cape Department of Health. We trained all of our enumerators before data collection, and the questionnaire was administered within people's homes. The head of the household, or the most senior person available at the time, was interviewed, and they were also informed that there was no benefit or risk associated with their participation. However, if participants required services that they didn't know about and the enumerators knew, they were given such information. Descriptive statistics we use to present the various components of disability, and as medical rehabilitation is the focus of this paper, this was chosen as the variable to discriminate between those able to access care and those in need who had not received an intervention. Chi-square was used to test for association between the categorical variables. The results: for those with disability, 45% were female. The mean age was 46.5 years, and the majority were unemployed. I think the previous speakers alluded to the high unemployment rate in especially South Africa, and Shivani mentioned that people with disabilities were less likely to be employed in South Africa. And that's true because it relates to our high unemployment rate. The unemployment rate in South Africa is approximately 40% at the moment. And we have a social system, so majority of the people with disabilities were receiving some form of grant. Related to impairment, majority of the people with disability that we interviewed, and this presentation is just the results will just focus on those people that were identified with disabilities. So the majority of those reporting problems on the Washington screening questions, 85% of them had mobility problems, and 77% reported a lot of difficulties or a cannot do in all of this area. And the next common problem was remembering, and only 39% reported a lot of difficulty or a cannot do. This is just a table representing the screening questions for disabilities. The causes of disability were post-coded and being unintentional injury and chronic diseases of lifestyle, childhood infections, and birth trauma. Infections only at 8%, and any others were at 15%. And I think this also speaks to the Global Health Report, and it reflects similar results. In terms of access to services, all of those reported being in need of services, the largest percentage reported that these needs were not met in the areas of medical rehabilitation, assistive devices, and home-based care. Home-based care being the largest. In contrast, only 2.5% reported being in need of medical care and not having received it. There was no difference in the proportion of males and females who had access to medical rehabilitation, and there was also no significant difference in the mean ranking of income categories, or those not receiving care had the lowest mean rank. There were fewer respondents with sensory and language disorders, but this group reported proportionately more unmet needs. Those over 65 years of age were less likely to have had the medical rehabilitation that they required, and those who had a disability secondary to infection were the least likely to have received medical rehabilitation, followed by those who had a chronic disease of lifestyle. The main problem with accessing services included inadequate finances and transport problems. Communication or language barrier was reported as a problem with accessing services by at least 48%. As I indicated earlier, South Africa has 11 official languages, and it is spoken in different parts of the country. So depending on which area you come from, you might have difficulty in having your language spoken at a healthcare service. 67% of those interviewed said that they were not satisfied with the service, and this dissatisfaction might be linked to the long waiting times that they have at the clinics or when they do present for services. The sample is likely to be representative of those who dwell in a deprived urban area, as the prevalence in this study, that was 5.2, is equal to the 2011 census data and the 2011 General Household Survey data. The mobility as being the most prevalent also reflects the census that was conducted in 2012. The information relating to service need and utilization may be equated with an assessment of performance of the respondents and the interaction with the environmental factors. This is defined in the ICF as involvement in a life situation or the lived experience of people within the actual context where they live. The discrepancy between access to rehabilitation care and medical care may be attributed to the Healthcare 2010 strategy of the Western Cape Department of Health that focused primarily on the curative and preventative strategies. Yesterday in a presentation, there was a question to cerebral palsy and whether there was an increase in the prevalence of CP. The strategy of the Healthcare 2010 and 2020 in the Western Cape had focused primarily on maternal and child health, and that could be the reason why there is less children or mothers were dying at birth, but the problems related with children were detected earlier. So more services are in place for curative rather than rehab. And there's also a large number of community health clinics in the area under study. However, very few of them have rehabilitation personnel. The worrying finding of the study was that over half of the participants over 65 years of age had not had access to services. The elderly represent a particularly vulnerable group, and this group should be targeted in any attempt to expand services. The home-based care services in other developed countries are mostly focused on the elderly, which is not happening in South Africa. The results of the study further indicate an urgent need to improve access to rehabilitation services, including the provision of assistive devices to people with disability living in this impoverished area. The report suggests that where services are minimal, basic rehabilitation services should be developed within the existing health infrastructure. What I can add, the implication of this research that we did actually feed into government strategy for increasing rehabilitation in the urban area. We are at the moment piloting the training of home-based carers in rehabilitation skills. So we hope that in future access to rehabilitation and especially assistive devices should improve. With the assistance of the US and I think the Gates Foundation, South Africa was given a grant to improve access to healthcare, but with a specific focus of human resources. So they've implemented the training of home-based carers, but as I said before, it was more a preventative strategy with main focus being on HIV and AIDS and maternal and child health. And those were for screening of children and mothers and more palliative care for HIV. And as the disease has actually changed with more people now living with the disease and with more disability, the focus of the work obviously has to change. It should be remembered that South Africa is categorized as a middle-income country, and sophisticated services that are available within the country should ultimately be expanded to the most disadvantaged people. The limitation of the study includes the need to rely on a self-report, which may have over or underestimated the need for access. A comparison of self-report, clinical examination, and a standard measure of work-related limitations for monitoring activity limitations demonstrated a considerable difference in results. Self-reported limitations were higher than those derived from clinical examination. I'd like to acknowledge and thank the University of Cape Town Research Committee, the University of Washington for allowing me to be here, the Europe Wall Group, and the Harry Crossley Fund for making it possible to do this presentation today. Thank you.
Thank you so much for the wonderful presentation. I had two questions. One was, can you speak to the response rates of your study and how generalizable your results are to the population? And also, there is a category you mentioned called chronic disease of lifestyle. And I was wondering if you could elaborate what those chronic diseases are and which one among them was the biggest contributors to disability.
Okay. In terms of the sample, I'm sorry that I didn't present that. I did say that we wanted a sample of 1,000. That was just the households that we surveyed. In terms of the household size that we got, there were approximately 3 persons per household. That then gave us a total for the entire study, not just the sample that I'm reporting on, but for the entire study, we had a sample of over 3,000 individuals, which then, with the interview, we had asked the respondent to identify any person with a disability using the Washington screening questions. We then identified in this particular area a prevalence of at least 12.8%, but only 152 of those individuals were available and agreed to participate. So we only interviewed 152, and those are the people that I am reporting on. The diseases of lifestyle, we refer to non-communicable diseases as diseases of lifestyle, and the most prevalent disease of lifestyle would be your diabetes and hypertension.
Hi there. I had a question about the slide you put up on barriers and satisfaction of services. I'm wondering if there's any comparable research or data about people who don't self-identify with a disability, and whether the 67.5% of non-satisfaction is comparable with all people accessing health services.
We did a previous study in an urban area, I think that was 2007, where we compared an urban area with a rural area, and we had similar results with regard to access to services and satisfaction with services. And as I said, when the population of people visit a clinic, which is a public health clinic, they generally spend the entire day there. And attitudes of clinic staff and medical staff was a major contributing factor to their dissatisfaction. So I would say yes, that the results are comparable to general opinion. Okay.
I had a quick question too. I just wonder if you could talk a little bit about the challenges of implementing this kind of research. It's very important. You're out asking questions directly, interviewing folks, conducting community survey like this. And I know how challenging that must have been, but how many staff, what were the big challenges in actually doing the implementation of the research? If you could just talk about that a little bit. Since this was a community-based survey, we used people from the community to actually conduct the survey for us. So many of them were known to the community, and I think people felt easier to discuss their feelings, or even these were home-based carers themselves. So people did feel comfortable to especially share their satisfaction or dissatisfaction with the survey or with the services, and also to say what they needed. In terms of, this was a funded project which made it easier to run. An unfunded project would be extremely difficult. We did this research in the Western Cape, And when we presented the results, the Department of Health was extremely interested, and they then commissioned us to do further research in a different area, which to us was brilliant. It raised the profile of rehabilitation. I was just speaking to Chappelle earlier to say that we've developed a new policy on healthcare, and we are planning to implement a national health insurance system with the intention of bringing more equal access to healthcare for all people. But within that policy, rehabilitation was omitted. There was absolutely nothing about rehabilitation. So this research highlighted again the need for rehabilitation amongst the population. And we don't know whether it's going to be included in nationally, but definitely for the Western Cape, they've acknowledged that.
Hello.
Yeah.
I'm from Nigeria. I don't know if in South Africa the fact that there are non-communicable diseases affecting other people have caused a different set of people to become disabled. Because like in Nigeria, because of the non-communicable diseases, very affluential people who have rich lifestyles have experienced things like strokes, heart diseases, and so it's causing a different genre, I'd say, of people to experience disabilities. I don't know if your research or any of the other presenters have noticed this trend, so to speak.
Yes, we have. We have noticed the trend. I think generally across South Africa, we're seeing that there is an increase in non-communicable diseases across the spectrum of the population. The reason why we tend to focus on under-resourced areas is because of the richer communities. They have access to services. They have medical insurance. They can afford to go to the clinics. It's actually in the poorer communities where services are not available. So physiotherapists, occupational therapists are readily available. They are there for people who can afford and can access them. But it's the lower income group that's the concern.
A good presentation yesterday from the cerebral palsy program for children, and I'm just wondering if any kind of a survey has been done regarding children with other sets of disability and rehabilitation and parental satisfaction with the level of rehabilitation or intervention for children in our country.
On the previous study that we did, and that was done in the Eastern Cape, which is more of a rural area in South Africa, we did find that people were more satisfied with services in a remote rural area than they were in an urban area. But we don't know whether we just have to attribute that to, as they said earlier, something is better than nothing, that they tend to be more satisfied. And this was primarily amongst mothers with children who had a disability.